I'd like to introduce our next speaker, actually our co-speakers. Our lead speaker is Mary Campbell Bliss, perinatal clinical nurse specialist at Sutter Medical Center, Sacramento, retired. And Dr. Herman Hedriana, Sacramento Maternal Fetal Medicine Medical Group, and Associate Clinical Professor of Obstetrics and Gynecology at UC Davis School of Medicine. Welcome.
We're going to do our session a little bit different in that Dr. Hedriana and I are going to co-present. We have no conflicts of interest, except that Dr. Hedriana does use an off-label use of betamethasone during the antenatal period. I'm here to talk today about the Preterm Labor Assessment Toolkit and then how that fits in with the use of antenatal steroids. And we're going to focus a bit on that. The goal of the toolkit is to improve perinatal health outcomes by standardizing a clinical pathway for the assessment and disposition of women with signs and symptoms of preterm labor. We believe that this toolkit complements recent ACOG practice bulletins, 127, the management of women with confirmed preterm labor, and 130, the screening and management of asymptomatic women at risk for preterm labor. So we believe that ours definitely complements it and falls into this area in between where women who present in hospitals with signs and symptoms of preterm labor, what do we do with them and how do we manage them? We do have a disclaimer for the toolkit. March of Dimes is not engaged in rendering medical advice or recommendations. ACOG's Committee of Obstetric Practice supports the toolkit. However, it is for informational purposes only and may not entirely reflect their guidelines. The protocols and policies that are in the toolkit were presented to us by various healthcare providers and institutions, and those were reviewed and modified for use in this toolkit. And it's important that any procedure or policy reflect the practice for an individual institution, so we want to make sure that everybody reviews the content carefully and revises applicable to your facility. So I want to talk a little bit about the history of this toolkit. And it has been a fairly long, involved, shall we say, gestation to get to this point, right, Leslie? It started back in about 2002 at the March of Dimes Prematurity Summit. And there was a group talking about the difficulty of assessment and disposition of this population. And the consensus was there really were no consistent risk factors that would allow anyone to determine which women were going to go on to have a preterm birth. We knew about half of the women that delivered prematurely didn't have any risk factors from the long list that we have, and about 2/3 of those that had that did have risk factors did not go on to have a preterm birth. So we really talked about the fact that we wanted to have a method established to how to deal consistently with women and appropriately treat or discharge them to home. It was also a consensus that women should deliver at the appropriate facility for the neonatal care that we had. So PLAT was developed originally through a cooperative agreement between the March of Dimes California chapter and Sutter Medical Center, Sacramento. And in that process, Dr. Hedriana and myself were the clinical leads for this toolkit. Right away, we knew, just like Intermountain talked about, that we really needed an interdisciplinary group, because if we were going to put out a toolkit, we needed all the voices of everybody that we hoped would use it. So we put together a task force that we had physicians, MFMs, and obstetricians. We had nurses, clinical nurse specialists like myself, as well as other nurse leaders. We had a midwife. We made sure that we had both urban and rural hospitals represented, and both public and private institutions. The California Department of Health Service Maternal Child Branch had representatives there, people that were in the regional programs, and then the March of Dimes was also represented. Dr. Byrne and Leslie were at some of the meetings. So we started off by asking hospitals that were in some of our California regions, would they send us their protocols? Because we wanted to get together and take a look at were there some areas that we had great consensus on, or in other areas where we didn't, because we didn't really want to waste our time on things that everybody agreed upon. And we had about, I would say, 25 hospitals that sent us protocols. And we guaranteed that they would be anonymous and that we just were using it for the purposes I described. And here were the things that we found out were consistent. First of all, everybody used electronic fetal monitoring for assessment of contraction patterns and fetal well-being. We all called the physicians or the providers, and we all reviewed the perinatal records and the patient history. But we found wide variation in other areas. The definition of preterm labor, I would have to say to you that many protocols did not contain any definition of what preterm labor was, which right away pointed out to us, how do you have any conversation between people when you don't have a consistent definition? The use of fetal fibronectin was very scattered. And for many of the facilities that did use it at that time, they were using reference labs that they were sending them away for instead of the rapid fetal fibronectin, which was fairly new on the market at the time. There were many institutions where nurses didn't do sterile speculum exams, and they had to wait for the physician to get there. And also there were lots of inconsistencies as to whether a nurse would even do a vaginal exam, and there would be a delay on that. And then many of the protocols had no information about disposition choices and what were the criteria for that. So this was the type of a process that we put together to really analyze the different protocols, and I'm only showing you 6 of them. But as you could see, here's the definition for preterm labor, and of the 6 I'm showing you, 3 had a definition and 3 did not. So you can see in here that some of these EFM was everybody did it. Whether they gave just oral hydration was mixed. But we went through this and tried to figure out what it was that we would take a look at. Because we didn't have the consistency of a definition, the nurse leaders that I talked to throughout the area talked a lot about inconsistent processes and how difficult that was for nurses. It created confusion. Depending on who was handing off to different providers, there would be different responses to the patient. And it caused patients to stay on units longer than many people thought they might need to. And that tied up staff, it tied up resources, and it tied up rooms that weren't available necessarily for other patients coming in. But the worst part of it was many people felt that women were being unnecessarily treated and that we were also perhaps missing the timing of the antenatal steroids because they were there and the decisions weren't being made in a timely fashion. So that was 2005 when we brought out this original toolkit, and that was a cooperative agreement. But in 2013, the revision of the toolkit has been just released. And I'm going to say, I missed this other slide. So anyway, we went back and we looked at the pertinent research for those topics, and we ended up doing the development of a protocol, algorithm, and supporting materials. The main thing that drove us, and I would have to say over and over, conversations would stop, was the overarching question was, could this toolkit be used in any type of a maternity hospital? because we had the tertiary level people there, and they had lots of resources, and they had lots of people available. But like Terry was saying, we also had rural hospitals, and they did not have the staff and the ability to get to things. So we wanted to make sure that what we put out, anybody could use. So in the revised toolkit, we took the definition of the ACOG Practice Bulletin 127, and that is that preterm labor occurs between 20 and 36 and 6 weeks pregnancy. And it has, generally based on clinical criteria of regular uterine contractions with or without ruptured membranes, initial presentation of dilation of at least 2 centimeters, or a change in the cervical exam on cervical examination. Again, identifying women with preterm labor who may ultimately give birth is difficult, and approximately 50% of women hospitalized for preterm birth deliver at term. Now, that was a group that we wanted to address and decrease unnecessary hospitalization and unnecessary treatment, and again, make sure we could hopefully identify those women that would require treatment. So what is the toolkit? Well, CPQCC says it's an all-inclusive package that helps facilitate clinical outcomes, excellent patient care, and efficient research utilization. And that's what PLAC is for you. It's a package of resources to help you standardize your preterm labor assessment at your hospital. And again, we go back to saying it is to be modified to meet the needs of your facility. So it contains an overview of the preterm labor assessment and clinical disposition options. It has an algorithm, it has a protocol and an order set for that time period for when the patient comes in to when you make the disposition. Some of the new things that we have that are a great addition to this toolkit is data collection information. So there are suggested measures and there are data sources for hospitals to be able to use. So there's ICD-9 and 10, CPT codes, audit tools. We've put that in there because if you're going to start a project, how do you know how to measure your effectiveness? There also is a look at how you could use this project as a QI, quality improvement project. And again, those were things that hospitals asked us for when we went out and talked about the very first PLAT. They said, well, it's great, but how do I implement it? We also end up with putting in patient education, key messages, and home care instructions. Again, I would say to you that this toolkit supports local providers and hospitals by giving them practical tools and resources that they can use to standardize preterm labor assessment. Again, I know that the primary care hospitals want this material. They've asked us for it. Anything that can help them improve care, and that's the group that we have seen over and over have a lower use of ACT than the other groups do. So this is a standardized pathway that we hope will help us to make sure that cervical change is uniformly assessed and that those standardized assessment can lead to appropriate disposition. Our pathway combines the clinical symptoms, clinical information such as gestational age, medical screening exams, fetal monitoring, and then adds in the screening tests that are available for us today to be able to lead down to appropriate dispositions. And if there's no cervical change, that we can send the woman home with educational materials and further follow-up. Because again, we don't believe you just send them off and say thanks for sharing. We really, really want to have follow-up so that we can continue the dialogue so they're still aware of preterm labor. But then for those that do have cervical change, be able to get the antenatal steroids started in a quickly and timely fashion. So in our process, we believe that from the time that the woman shows, within 4 hours, we should be able to make some type of a disposition decision, and that would allow us to do appropriate actions. So prior to doing PLAT in 2005, the potential of using a programmatic or quality improvement process to decrease the admission of women that appear at your doorstep with signs and symptoms of preterm labor and overtreatment hadn't occurred anywhere. The current PLAT draws on the experience of March of Dimes because in California we have worked to implement this in about 40 hospitals. And the lessons that we've learned in doing that have been applied to a lot of the QI processes and the things that are there. So we believe that identifying women that are in true preterm labor will benefit everybody who presents in triage. And hospitals who can all levels of care, again, anybody that can use this will have timely and appropriate interventions, provide optimal maternal fetal safety, hospitalize only those patients at greatest risk, allow for effective transfer of patients to higher, more appropriate levels of care, and equally important, avoid unnecessary treatments, interventions, and medications. I've included this one study from Rochester or Mayo Clinic because they used a standardized procedure or triage protocol that was patterned after the PLAT, the original PLAT. And in the 1 year that they did this and looked retrospectively, they found that they reduced the admissions of women with symptoms of preterm labor by 56%. And the safety of this process was confirmed. They did not have any adverse pregnancy outcomes. The mean gestational age was about 38 3/7 weeks when they delivered, and there was an interval average of about 8 weeks between evaluation and delivery. There's copies of this study out at the information table, at least there were yesterday, if you're at all interested in it. So ACOG talks about the fact that interventions that we've historically used have really not been very effective and should not routinely be used on women who have signs and symptoms of preterm labor. We want to avoid any of these severe lifestyle changes unless absolutely necessary because there are some harms that come to women when we do this. There are risks of thrombosis from bed rest, but the fact that you are changing their lifestyle so dramatically can impact their income and even lead to a loss of jobs. And so some of these things should never be underestimated as to the impact on families. Interventions that do reduce risks, and we've talked about several of those while we've been here today, including progesterone, can work to help prevent preterm birth, but PLAT focuses on preparing for preterm birth. The fact that if we can make an assessment and find women that are the highest risk, then we can move in a rapid fashion to help prepare for the birth, such as administering the steroids, assembling the neonatal team, and preparing for transport to a tertiary facility. We certainly have talked about the fact that we are now measuring use of antenatal steroids, and we've talked about it being the most beneficial intervention for women prior to delivering, and I won't pay any more time on this because I know we're a little bit short. We've also verified the fact that there are probably in about a quarter of the women who could benefit from this who are not getting it. I went back into the Big Five survey to look at comments because we're going to come up with a few policy recommendations at the end. And these are some of the comments that I pulled out that relate either to the recommendations or to what we have included in PLAT. One of the hospitals said, we really have an issue with patients transferred to us. It's hard to find how many doses they received and when. And I know at our tertiary facility it's the same way. We don't get a particularly good report, and then we may not be able to find it in the materials that they've sent to us. Again, you may go back and ask her if she got steroids, and she tells you she got a shot. Difficult to find the documentation if patients are received from an office or clinic or at a referral hospital or remote from delivery hospitalization. So maybe she was hospitalized once before and got steroids, but you don't have her chart coming up, or you just don't have the method to find it. Please include plans for level 1 facilities regarding timing of implementing ACT, because we don't routinely deliver patients less than 33 weeks, so what are we supposed to do? This one said our practice is to offer ACT to all patients at significant risk. And the word offer struck me because we had that big discussion the other day about, do we offer or do we talk about the fact of the importance of doing this? And I'm not sure what they meant. This one said we don't have antenatal patients and they're given the steroids at the transferring hospital. And so that's one of the concerns that I have, is that there are hospitals that don't give the steroids before the transfer. Number one, it takes too long because maybe they don't have a pharmacy that's open at night and they can't get a hold of this. And their thought is, we'll just get them out and get them to the transferring facility. And so that is an issue. We'd like you to reduce variation through adoption of standing orders protocols to help drive the change. And those are placed into PLAT for people to use. And someone said create an order set for patients with suspected preterm labor. So I want you to know that in the comments we got from people who participated in the Big 5 survey, they were looking for some of the things that we have included in the new revision. And now I'm going to turn it over to Dr. Hedriana, and I will come back up in a few minutes.
Thank you, Mary. So here I'm just going to go a kind of an overview briefly of the science behind why we're doing this. The details with regards to the toolkit itself is in the binder outside. It can also be downloaded, and it has all the information that you need. So the main reason why women come into triage is because they think they are in labor when they have frequent uterine contractions. They don't know what their cervix is. They don't have any other symptoms. Sometimes they do. Sometimes they have low back pain. They may have some spotting. But if we base the diagnosis solely on contractions, most of the time it's inaccurate. And contractions can happen to as much as about 4 times an hour in about 25% of cases less than 32 weeks. And if we use 6 contractions per hour, a majority of these patients actually end up delivering a term. This is one little study from Wisconsin, kind of showing you the common practice in community hospitals where they look at contractions as the main event when patients come into triage. So 239 patients presented with preterm contractions. The average gestational age was about 32 weeks. 17% of this patient had cervical change with the contractions. And what they found out that 76% of those without cervical change received short-term tocolysis and then end up being discharged home or admitted. And only 33% of those delivering less than 34 weeks received antenatal corticosteroid therapy. So the reason why we're focusing on contractions is because we don't want to get ourselves in this spot where the woman is in active labor, she's more than 3 centimeters dilated, 80% effaced, and bleeding. So by the time we get to that, if you look at cervical change as a train, you pretty much are too late to give the antenatal corticosteroids. But if you anticipate too much, then what happens is that you end up more people on the train, you have inappropriate use of antenatal corticosteroids. So that's kind of where we're at, and that's the reason why we decided that a standardized way of approaching this would probably make a difference. So when contractions are confusing, patient comes in, you don't know what to do with them, you have all your resources available, You tried all your tests, you do fetal fibronectin, you do cervical exam, she's still contracting. Then you just decide after 23 hours of observation that maybe I should just admit her, settle her down, sedate her, put her in tocolytics, and see what happens next. But 50 to 80% of these women would be discharged undelivered and then deliver at term. But with standardization, you're able to reduce your antepartum admission and length of stay in the triage, decongest the hospital, you reduce the use of tocolytics. You also increase the use of antenatal steroids by specifically picking out the candidates for it. And in turn, you do have cost savings, as was shown in several studies. So the tools we have to standardize this process is one, the definition. A definition from ACOG. Consistent definition is important. So if everyone understands that we make a diagnosis of preterm labor only if the cervix is changing, there is dilation, or after serial examination. But then we come to the quandary of what if there's no change, or whether the symptoms continue, the cervix still feels the same. And the only thing that we have right now in the literature that has been truly used is transvaginal ultrasound and fetal fibronectin. Now, Jay, of course, as everyone knows, did the initial studies on transvaginal ultrasound and looking at cervical length. And this is mainly an asymptomatic patient. I don't know of any randomized trials on cervical length measurements in triage where the patients are actually symptomatic. Maybe the Rose study that Mary cited would be one of them if you really look into that. But on the left panel, you'll see a normal cervical length, which Larry also showed earlier. And then below that panel is the abnormal cervical length where you have funneling and shortening. The diagram you see is Jay's work looking at the relationship of the probability of preterm delivery with a shorter cervix measured at 24 weeks. Now, there are technical challenges in doing cervical length. Not everyone can do it. Not in a hospital that has only 29 births per year. I mean, they don't even have an ultrasound sometimes in their triage unit or their emergency room. But here on the left, you'll see a cervix with a shortened cervical length with funneling. If you move that transducer just a little bit after 17 seconds, you can make the cervix look normal. And this is courtesy of Dr. Byrne. So what are the limitations? If you measure the cervix less than 15 weeks, most people believe the lower uterine segment is not yet developed, so you are measuring an extra long cervix. After 28 weeks, physiologic changes happens, as was mentioned earlier in the prior talk, and you may be looking at a short cervix, which is really not threatening. The learning curve is fairly steep. We've noted, talking to the community hospitals, especially transporting hospitals that are over 100 miles away from a tertiary center. In some cases of vaginal bleeding or placenta previa, there is hesitancy in doing transvaginal ultrasound. This is where they have to wake up on MFM at 2 o'clock in the morning to come in to do cervical length measurement. Excessive probe pressure, as I shown earlier, can make the cervix look normal. If the maternal bladder is filled, it can also be uncomfortable and make the cervix look different. And then, as I said earlier, in most community hospitals, there are limited access for transvaginal ultrasound equipment and trained staff. This is one of the studies that Jay and Vince Vergela did, kind of just showing the correlation between the short cervix and the probability of preterm birth, especially in women with prior preterm birth. And as you can see, at 26 weeks, the cervical length of 15 millimeters is associated with 16.2% risk of delivery prior to 32 weeks, while a 45 millimeter length has only 1.5% risk. Then there's another, the biochemical marker that everyone is talking about is fetal fibronectin. It has been around for over 20 years. And there are studies using it in symptomatic women. And I think it is in symptomatic women that we see the best outcome in terms of trying to use this. So it's normally seen in pregnancies between 22 to 35 weeks. Undetectable between 22 to 35 weeks. And over a range of studies, the positive fetal fibronectin has been associated anywhere from 13 to 40% delivery within 14 days. However, The negative predictive value, fetal fibronectin, is anywhere from 0.5% to 5% within 14 days. So the data of positive predictive value and negative predictive value can assist us in assessing the risk for women who present in triage. Now, there are also limitations. So per their insert, it's invalid for less than 24 weeks or greater than 34 weeks because the likelihood of a positive test is much higher, or it can have a false negative test less than 24, or whichever way you want to go. A sterile speculum examination for collection is the only FDA-approved way of doing it. It's contraindicated in vaginal bleeding. If there's prior intercourse or an examination of the pelvic area in the last 24 hours. If the cervix is over 3 centimeters dilated, if the membranes are bulging, if the membranes are ruptured, or if there are any open cervical lesions or vaginal lesions that are bleeding. The thing about the two tests is that if we apply the 20/80 rule, the majority of patients presenting with contractions would probably have a negative test, and a few of those will have a positive test. And so we're going to go through that. The algorithm itself looks like this. I'm not going to go through each little circles and squares, but there are copies in the table outside for you to look at. The highlights are, the first thing is that the patient comes in to be evaluated. We recommend the evaluation should be done within 2 to 4 hours. You'll be able to make a decision whether to admit the patient or send them home. Then the nurse who's actually seeing the patient has to reassure the patient and their family and kind of explain the procedure, what they're going to be doing. The nurse then will review the prenatal records and then inquire about the previous preterm deliveries just to assess her risk. Then they would obtain objective data. They put the patient on the monitor to assess the baby, assess for contractions, routine labs that are ordered by the provider, a sterile specular examination to assess whether there are ruptured membranes if the patient is symptomatic, or to obtain fetal fibronectin and other specimen for culture and other tests. And then a sterile vaginal examination to assess for cervical status in terms of dilation, consistency, and to see if there are, as a baseline examination upon arrival. Then you can have the preterm labor screen, transvaginal ultrasound ordered if there's availability, or send for the fetal fibronectin, then inform the provider. So the outcomes can be several. Option A, if you stick to the definition and you have these findings, then you think that the woman is in preterm labor and that's how you made the diagnosis, then you can notify your provider. You can administer antenatal corticosteroids if that's the order set that's provided, or if the physician orders it. Initiate short-term tocolytic therapy if you want to transfer the patient to a higher tertiary level or a higher unit appropriate level. You can admit the patient if you decide to do that, or you can activate a different kind of pathway in terms of treatment for this patient. Option C is the opposite of option A. Everything is negative, you're reassured, woman still is contracting. You can notify the provider, you can do some teaching, and we make it a point for this woman to be followed after a week just to assess, because the risks don't go away, especially if they have prior preterm birth, so that's very important. And then you discharge the patient for the follow-up. Now, option B, which I think Jim is going to comment more on later on, is what we would consider if you're looking at fetal heart rate tracing as category 2. But this is like all comers, basically. But this is where you have to fine-tune your clinical acumen and make a decision whether these patients are going to be at higher risk of preterm birth, or it's a normal finding to see them at this stage. A positive fetal fibronectin, which I said occurs less likely than a negative one, is one of those quandaries where you have to make a decision whether to start antenatal corticosteroids or not. And then option D is if you don't have the technology available to make the diagnosis, or to help you assess, to come up with a diagnosis of preterm labor. And in this case, you do a serial vaginal examination. And of course, if there's cervical change, you do all the process of admitting the patient, giving antenatal corticosteroid treatment, or if there's no cervical change, then you can go and proceed and send the patient home. Now, in those patients who are between 20 and 23 weeks and 6/7, it's a bit of a challenge. A vaginal examination or a speculum examination cannot readily detect any cervical change, and then it's also below the cutoff of the FDA-approved testing for fetal fibronectin. So this is where transvaginal ultrasound would give you a lot of assessment. So in this case, we suggested that if the cervix is less or equal to 15 millimeters, then you can offer a rescue cerclage for appropriate patients, or start daily progesterone, a vaginal administration. If it's less than 25 millimeters, again, consider the clinical situation, the prior clinical, the clinical history of preterm birth, and then do progesterone or offer cerclage. And those for women who are 23 or equal to 23 weeks, then we can offer our antenatal corticosteroid treatment. Now, for those women who are 34 to 36 and 6/7 weeks, we assume that they're in prodrome labor, which is a common challenge. We don't know where the end point is. There's no data that support you have to intervene for this patient. So in this case, you observe and see if the patient makes progress. Patient doesn't make progress, education comes into play. And you assess this patient just like you would in triage every couple of hours to see if there are any cervical changes. In that way, you avoid any unnecessary intervention. Then you have a chance to educate the family and the patient with regards to their expectations. Now, evidence gaps from the toolkit is that we don't know what the characteristics of the population that will not deliver even if we make the diagnosis of preterm labor. And option C, in a negative screen, we want to know what our rate of false negative is, the rate of preterm delivery. Option B, the category 2 option, the rate of preterm delivery and whether the antenatal corticosteroid therapy is beneficial. And for the D, where you don't have any ancillary device or any other way of assessing the likelihood of preterm labor, the rate of preterm delivery, the effective length of time of observation, the triggers requiring antenatal corticosteroid therapy, and the triggers requiring antepartum admission. Now, with regards to the presentation prior to the stock, we look forward to the outcomes of genetics, the inflammatory indices, the biotechnology, the quantitative fetal fibronectin, and see how those studies pan out and how we could actually integrate them into the toolkit. And the last line there I just pointed out for discussion. And I'll give you back Mary.
So we had a fair amount of discussion of what could be some policy things that could help us within this topic. And of course, the first thing that came to mind was the fact that we really would love to see a national dissemination and implementation of this toolkit. And using some of the models like the less than 39-week elective deliveries, one of the thoughts that came to us were using the health engagement networks for distribution and training. I know that many of them have used the less than 39-week as an obstetrical measure and trying to get that implemented, and we look to them as possibly a vehicle for doing that for PLAT. In addition, in California, ACOG, California District 9, California has decided to be the lead in training providers throughout the state. And so far, I think 3 regional trainings have already occurred. And so that might be an option for other states to follow as far as getting something like this implemented. We'd like to see a formalization of ACT. In other words, make sure that all primary care hospitals understand that they need to give the very first dose and how important that is. And like I said, to help them to solve some of the issues around having that available to them in a timely fashion. And like Terry and I were saying, it sometimes can be very difficult in these small hospitals to get the steroids to be available to them when they need them. and then try to figure out how it would be best to have a standardized documentation method so that it is clearly available, and perhaps something like a transport checklist where that is on there and the date and time given, and it's part of what comes with that patient to the transferring facility. But it would be very helpful to us on the receiving end to have a real formalized method for being able to find that. And then we've had discussions about the electronic medical records, and there are a variety of them out there, and some of us have been struggling over time to find a way to use that technology to be of assistance to us. I know that we have centricity right now in our labor and delivery area, and what we did at Sutter Medical Center, Sacramento, is we had ended up with sort of a thing where the neonatologists were telling us, look at your VON data. It's really not very good. And you guys aren't giving steroids. And the perinatologists are saying, yes, we are. And so we decided to drill down and find out the issue. And the issue was around documentation. And we used the electronic system that we had, that when the nurses found out that ACT was done, they'd put it in, it would flow over to the doctor's screens where they were charting. And if it wasn't given prior to delivery and they were of that gestation, a pop-up question would come for the physician saying, why wasn't this given? And we developed with the physician many reasons why it might not be given, and they were able to do that. And since we did that, probably 2.5 years ago, we've had 100% of ACT for all appropriate infants. I've heard of some that have a mandatory fill screens on admission order sets. You cannot institute prenatal preterm labor assessment admission forms without a screen popping up saying, was ACT instituted during prior to the current encounter, yes or no? Was it instituted during this encounter? So that they mandatorily have to fill something in. I think we need to work with the various providers, Cerner, Epic, whatever, to come up and say how important this is, that this data element becomes very prominent on the delivery record so that our neonatal colleagues know what was accomplished. We also talked about incentives to try to enhance the moving of the mother to the appropriate level of care. And like I said, I live in an area where we have long distances. It might be 3-4 hours away from a regional center. And there are some financial problems for the providers when they transfer. Where we are, it's often a global fee that you get for care of the patient and the delivery and managed care. And if the provider transfers that patient, they lose that global fee, and they now have to go back and bill for every single visit. Well, that's a big burden. And in other areas with insurance, you lose the delivery fee. So we'd like to propose that there should be some reimbursement of a portion of the delivery fee to the provider if they give the first dose of ACT and they transfer to appropriate level of care before the delivery. So do some incentivizing to make this a little easier. We also have found that we have difficulty transporting the neonate back to the home hospital, even though they could be there because the care could be delivered at that home hospital. And the problem is, while insurance will pay for the transport out, many of them will not pay for the transport back. And so what happens is, if we do it, the hospital that's getting them or sending them has to eat the cost. So we'd like to propose that we advocate for a consistent payment by insurers to transport that infant back, because again, I think it has an incentive, number one, to help with bonding and all the other things, but an incentive to do the transport because they know that they might be able to get back home. And lastly, we'd like to open discussion of perhaps a preterm delivery quality bundle that would enhance a little bit about ACT, whereby a standardized preterm labor assessment is completed and there is an appropriate admission or transport, and ACT is given prior to the delivery of transport. And perhaps by having all these elements, you could get a proper reimbursement from the insurers and perhaps a new quality certification if you can show that this is happening at a high level at your facility. Herman said that you can go out to the March of Dimes booth. There's a hard copy of the binder. If you're interested in having one sent to you, they'll have a sign-up list. And these are the links that you can use to download it from the website. Thank you. Oh, and now, yes, and now Dr. Byrne is going to.
Jim Byrne, singular, not Scott Byrne, plural. Two words come to mind for me from this conference so far: inspiring and humbling. This has actually been a really wonderful forum, and there's been so many speakers and so many conversations even happening outside at breakfast. Has been really fantastic. In the interest of time, I just want to go over a couple things, 0 slides, and set up for any questions or answers that might be had. First of all, I want to reiterate that some of the background information for PLAT might be helpful for people. First of all, show of hands, how many people were aware there was something called a preterm labor assessment toolkit? And how many were not? All right, great. One of the aspects with PLAT is that this was actually designed in a format particularly to be actionable. And so you'll actually find that when we started the process in 2011, antenatal steroids and better utilization of antenatal steroids to improve outcomes for neonates was actually core of how we were trying to use and position the assessment. The other aspect that's good to know behind the scenes that this was designed from the beginning for a sense of scale. My background is that I actually had started work with perinatal collaboratives back around 14 years ago when I was with the HCA Corporation. I was one of the physicians on the physician work group. So like many of the individuals in the room with these really wonderful stories, I was touched really early on about the impact of policy, the impact of finance, and better care systems to improve population care. So we had about 200 hospitals across 15 states, 250,000 births a year. And you quickly learn pragmatically that something that sounds good in a committee room often is very challenging to implement on the ground. And that's because there's so many local factors to be considered. There's factors of the physician and nursing culture. There's factors including the staff, policy factors, even healthcare finance factors. So when we went into developing this second generation of PLAT, those kind of impact to scale was something we considered. And so it is moving to do another component of hitting a specific target audience, primarily of community hospitals who have a need for guidance and structure. Another characteristic is looking to standardize. There is huge variation in utilization of steroids for appropriate patients, but there's also huge variation in definitions of preterm labor. So ACOG's practice bulletin from June 2012 was actually ideal timing because it gave standardized definitions of actual preterm labor, which had been lacking as a formal consensus. The other components besides those were really looking at scale from the standpoint of having something that could be implemented nationally, and this was taking on lessons learned from the less than 39-week toolkit, where we learned to have that be effective not just in one area of California, but actually helping small communities throughout the South. We had to take into account that there are variations in nursing practices, for example, that are key. Performing sterile speculum exam is within the nursing practice for many states, and it's outside the scope of nursing practice for others. So if you delve into PLAT, and I encourage everyone to do so, I think you'll find that there's an awful lot of core elements in here to help provide maternal care delivery that improves neonatal outcomes. And finally, keep in mind, PLAT was designed from the get-go to be a living document. It is meant to change. It's meant to take the emerging data, including the amazing things we've heard even during the last day and a half, and incorporate these in time so that, again, that the end users, those physicians, nurses, and midwives who are in triage at 2 in the morning, can't have something that's both consistent with the evidence but also practical for their local environment. So with that, I'll open it up to questions. I appreciate everyone's time.
I'm going to try to make this question not sound inflammatory. So preterm labor, the clinical presentation of preterm labor is to angina as preterm birth is to MI in my question. Just hopefully accept that for a moment. Is it acceptable for a site of care, an emergency department, to not have the ability to do an EKG or cardiac enzymes in the initial evaluation of angina? If the answer to that question is no, it's not acceptable, then is it appropriate to have a minimum standard for the evaluation of a patient with preterm labor symptoms, regardless of the size or scale of a facility, to determine ongoing need? The reason I'm asking that question is if evidence and supporting expert opinion says that adjunctive tests in addition to clinical assessment are required to make that appropriate triage and transport decision, then maybe the bar is too low in our OB facilities around the country. I'm saying that fully cognizant that I run a obstetrical facility that delivers nearly 12,000 babies a year, but we have a large rural population network with transport, et cetera, and we have tried to bring at least that level of the same assessment of preterm labor to all of our very, very small referring hospitals as well. It's just that sounds more like a rant than I wanted to sound like, so I apologize for that. But there was a question in there. Is that a appropriate standard, or is it too high of a standard, an unfair standard to hold to OB evaluation sites?
You mean specifically the availability of resources such as ancillary testing, such as ultrasound and fibronectin?
For example, right, or ones that we develop in the future. Hopefully we do, but by principle, that if the notion is that clinical assessment alone is insufficient to either have a train that has passed you or train with people hanging off of it, if ancillary testing is part of the evaluation, which sounds like it is that a minimum bar?
Yeah, I think that's a really good question because, again, pragmatically, that's what's so incredibly variable between hospitals in any given community, and particularly a geographic location or a regional location. Herman's analogy to electronic fetal monitoring in Category 1, Category 2, Category 3, I think we're all good with Category 1. A woman comes in, cervical not changing, contractions go away, very good. Now, historically, there has been so much concern about preterm labor that many of these women have in the past been admitted and received steroids. And that's one of the really good benefits of the recent technical bulletin, that hopefully providers feel they're in safe harbor using a clinical exam, lack of contractions, and dispoing out the door rather than giving steroids and admitting. Category 3, I think we're all good with. Someone walks in at 28 weeks, 5 centimeters, I think we're all chill. It's that second group. Mm-hmm. And so knowing how many women will have contractions and no cervix change and deliver at term, but knowing that should you have that, say, 1 out of 8, 15% risk of going in and delivering, particularly at less than 30 weeks, if you have that information and we have a readily available treatment modality of antenatal steroids, where the administration cost is going to be typically about $120, but the medication itself is roughly $20 to $40, and we miss this window, I think this is a great example of, do we have the capability in these small centers to do secondary prevention? We cannot prevent the preterm birth necessarily. They're either going to go to term or deliver early, but should they deliver early, can we do secondary prevention of all the morbidities and mortalities associated with prematurity? So, long answer for the question, saying I think it is a very valuable thing if hospitals have the resources.
And to answer your question directly, I think it's a high level. We're looking at a town with a population of 1,000, a birth of 20 per year in a small hospital. The priority is for more of MIs, chest pains, stroke, rather than obstetrics. So a woman rolls in with preterm contractions in the ER. They have no obstetrical unit. They listen to the heart tones. They do a pelvic exam. That's pretty much what they could do. And what we realized in going through California is that in these small community hospitals, they can afford the fetal fibronectin machine but cannot afford a $100,000 ultrasound machine. The probe alone, vaginal probe alone, can cost anywhere from $10,000 to $25,000. That's 5 PLI machines.
So what you presented as a triage step, though, included fetal fibronectin and its cost. There are a lot of certainly social, economic, and political factors at play. Right? I don't pretend to be ignorant of those. So certainly in my area, I'm aware of those. I just don't see the same pressures on small institutions that may be small and see relatively few preterm births, but relatively few MIs. They may have a cath lab. They may have a cardiologist on call. They can't offer fibronectin in their hospital.
I think they can. I think we're looking at another area in obstetrics where we're sort of perhaps behind our neonatal colleagues, because at least in California, and I do believe across the country, there are state standards for different NICUs and the requirements for staff and equipment. And in OB, we don't have that. We
Right.
really don't. And in some respects, okay, that's great, but the stuff that I think you measure or the stuff that's required makes it at a higher level for perhaps people to pay attention to it. And I know that people in the trenches and trying to fight for budgets and resources, some of these things as standards are very helpful for them because they can't get the attention to get this limited pot. So I agree with you. I think at a minimum, some of this technology should be available with the skills to use it. But the political will and the other parts of it can be lacking. So I agree we should have it. I don't think we can have transvaginal ultrasounds everywhere, but I do think there could be other opportunities there.
Okay, thank you.
So actually, I'm going to pursue the same line of questioning, which is to say, I'm sure if we gave Dr. Simham, Dr. Wapner, and Dr. Rand an afternoon, they'd come up with a low-cost ultrasound machine that everyone could use. Maybe they'll have that tomorrow for us. But also want to understand the second part of it, which is my understanding that part of it is the training of people who would know how to read a transvaginal ultrasound. And so maybe that's the real scale problem at this point, because the choice is, should we bring the patient to the test or the test to the patient?
But I think there's one other part of that, and I think that when you think about an EKG and an MI, there's the data to say, do you have to have a transvaginal ultrasound to assess someone in labor? I mean, we know it's a component, but in order to say something like every hospital has to have a transvaginal ultrasound, competition of resources, right? And although, McGee is great at it, we just don't know that, do you need to do a transvaginal cervical length in order to assess labor? And so I think that the things that we do need to have, we need to be able to have the data before we ask hospitals, you have to have fetal fibronectin. I mean, there are lots of big hospitals that have chosen not to use fetal fibronectin in assessment of preterm labor. So I think we have to make sure that before we ask and say, we need these resources and we need to use these scarce resources for set things, we just need to make sure that we're following the protocols with the data in the lead. I think that's what I just wanted to add. Can I ask one other quick question while I'm up? The ACOG SMFM guidelines on short cervix. I noticed that you guys, you don't quite have the same algorithm that's been published. Is it getting revised to follow the guidelines around the part that you presented about 20 to 24 weeks and when to offer cerclage, when to offer vaginal progesterone? Are you guys revising that to put it more in line with the SMFM?
Well, what we tried to do was distill the data to the point that it's robust enough that people can interpret it. So we did not want to kind of give them an algorithm and say, this is how you should be doing it. So If you look at the toolkit, there are some appendix that are added onto that, kind of further discuss that and what the options are.
Yeah. PLAT really is designed for symptomatic preterm labor in that gestational age, because it's with ACOG. And yet we know those interested in the subject matter would have interest in other things, such as progesterone, such as early steroids or late steroids. So as we were preparing this document, again, it's a living document, should mature over time. That was prior to the ALPS study. You know, I'm at an MFMU site where we enroll in ALPS, which is going to be fantastic once collectively we have that information. But you'll find that the toolkit at least brings up these subject matters and then directs people saying, we don't have a stake in it now, but here are other areas where you could learn more.
Okay, thanks.
And I just was inspired that, you know, we have the perinatal transport form, but we don't have the maternal transport form. And so in California, we really need that. And then I love that this is a living document that's going to change over time, because we could develop some way to give the hospital a simple way to track when the antenatal steroid was given and when the person actually delivers, and help use that as a quality improvement tool. So those are my two thoughts.
Hi, I just wanted to say something about staffing guidelines, because somebody mentioned that earlier. A1 does indeed have a very comprehensive set of staffing guidelines that includes the recommendation for one-to-one staffing during the initial triage period, and also one-to-one staffing for high-risk patients, patients with complications. With the same kind of cautions and disclaimers as the March of Dimes presented for the toolkit, that these are guidelines, and one of the things that we are working very hard at right now is to help systems and facilities understand the impact of nurse staffing on patient outcomes. Similar to what our colleagues have done in the medical surgical nursing world, we are now doing in the OB perinatal neonatal nursing world. We also have a project underway right now, and don't have any results because this is just beginning, but we are currently testing a maternal fetal triage index. And so there are a number of nursing assessment parameters that are included in that index, and one of the things I'll do when I go home is see what there is in there about ACT. So I just wanted to let you know that we do have staffing guidelines and that are applicable for these circumstances. Thanks.
Eugene Toy from Houston, and I just really want to congratulate those who are involved with the PLAT. I don't know if those who are not in obstetrics understand how difficult it is to put such complex ideas and disparate views into something that is really very usable and practical, and not only on the physician and specialist and subspecialist side, but really for our nurses, our midwives, and for those, and even for on the patient side. In Texas, we are developing not only neonatal, but also our maternity levels of care. And I chair our council that is taking care of that. We have over 250 hospitals in Texas that do deliveries, so I had a chance to look at the PLAT and thinking about how different hospitals, especially the smaller ones, would use it. And I really appreciate the fact that those who put together the PLAT, that it's not prescriptive, it's flexible, and also that it's usable for different types of hospitals in different settings. So just really want to make sure and reinforce that at each individual hospital, they do have that flexibility. One also important point is that it should not be viewed as simply, if you follow these directions, you'll have good outcomes. There needs to be constant surveillance and the ability to record what happens at that institution, and are we really, is the fetal fibronectin working? Is our assessment tool really working the way it should? Are the patients getting the antenatal steroids, or is it instead either over or underusing? Thank you.
So let's thank our speakers.